name is Jenny Pope. I'm a sociologist working in the health area. For a few decades, I've been working in academia on primarily on health inequalities and social injustice. I have worked in the community third sector, we call it in England, the voluntary sector, and spent a little time in outside of the UK, in New Zealand and in Uganda in East Africa in my youth, which was very formative. I think the community health is one of the most complicated concepts. It's bringing together two very complex social concepts and contested, right? So on the one hand, health. So my particular perspective, as I said, is around health inequity, in the kind of gross inequalities in life, in any way in which you think about health and ill health. These vast inequalities in life expectancy, in people's experience of serious disease, of mental well-being. So for me, health is always about health inequalities. Not for everybody, of course, but that's how, if you say health to me, I automatically think about health inequalities. Community, as a sociologist, you know, that's a very complicated concept, and it's not one that, so these two words I tend not to put together, community health. I understand that it's widely used in the health field, but I think the problem with community for me is that it's an ever-changing concept. It's a very gendered concept. So if we're thinking about communities of place, neighborhoods where people live, then that's the space where women do most of the work. So I suppose if I do use the word, well, I tend to use it in the sense of a group of people who share common interests, and that might be people who live in a particular place. It might be groups of people who have particular issues in common, but they have to recognize that shared interest to be a community. So I think we often use community in a very inaccurate way to talk about people who are living in a particular place or in a particular town or a village, and that those people may not have a shared sense of their common interest, their sense of belonging together, and the way in which they can act together to improve their living conditions. So for me, I tend to talk about population health inequalities rather than community health. And community health practice, I would tend to talk about public health practice. I might use the phrase community activist to talk about somebody who is actually acting on behalf of a group of people with common interest to try and improve things for them. So it's complicated. Well, I think we've learned that, so all these years we've been doing community health globally, you know, all of us have a particular focus, don't we? I mean, I work in England, and it's one of the richest countries in the world. It's one of the countries with greatest inequalities in the world, social inequalities, health inequalities. So most of my experience in the last few years has been about working in neighborhoods in a high-income country, right? But I think looking globally, what we've learned is that whilst there is obviously a lot of very good work goes on in relation to working with people living in places, neighborhoods, over the period of 5-6 decades, inequalities have got worse, you know. So actually, what we are doing may be having some really locally important impacts, but it's not changing the gross inequalities in health and social conditions. So I think we've learned we need to rethink it, actually. I think there are people doing that, but I don't think there are enough people doing that thinking about if this community activity is going to have an impact, how do we have to change it to have that impact? Well, I think there are several different strands to that, aren't there? The one thing that it has absolutely done around the world is make these social inequalities that are generating health inequalities more visible. I mean, they were obviously there before, there's no question. In fact, in a country like England, we walk past them all the time, people living on the streets with no homes. 1/3 of our children living in poverty in England, 1/3 of children in poverty in one of the highest income countries in the world. So it wasn't that we have, COVID hasn't created inequalities, but it has made them more visible. And undoubtedly, both globally, nationally and locally, it's exacerbated, it's made them worse. Whether that's because of the socioeconomic impacts of the pandemic and the response to the pandemic being unequal, or the actual incidence of the disease, and now long COVID, which is leaving, of course, millions of people in the UK. The last estimate, the minimum was 2 million people at the moment with long COVID, debilitating conditions. So it's made existing inequalities more visible. And now there is growing concern, certainly in Europe, that it is going to become a disease of poverty. So as we grab the vaccines in the high income countries, fail to share the vaccines out equally. But even in our own countries, the place in England, the places with the highest COVID rates and the most severe illnesses are all the disadvantaged neighbourhoods. It's like a map of social inequality, the COVID map. So people are beginning to say that it's becoming a disease, another disease of poverty. And as we maybe recover, certainly move out of some of the worst of it over the next few years, it's possible that these communities are going to be left with COVID on top of everything else, So I think it's made some people even more aware of the need to, the challenge for public health, the challenge for community health is to reduce social inequalities, to pursue social justice. I would say that, one of the key things that people working with communities of interest in places, in neighbourhoods, one of the key things they can clearly do, assuming that we're talking here about those communities that are bearing the burden of social injustice, then clearly supporting them to access all of the services and resources that they can is really important. And recognize, I would not belittle that. I think it's really crucial. But I think sharing knowledge with these communities of interest is also a really crucial thing. And I would say sharing knowledge, not transferring knowledge. It's about recognizing the enormous wisdom from lived experience of social injustice and bringing those different forms of knowledge together. So I think a kind of level of humility about the knowledge that the kind of health expert brings, the professional expert brings, is really important for this next cohort to kind of recognize that one of the inequalities that is a real problem is epistemic inequalities, the way in which we value different kinds of knowledge. And I would hope this next cohort of young health activists, health professional activists, will be more humble about the nature of the knowledge they bring and the knowledge of the people who they're working with. But I think above all, I would say, I think one of the problems that has limited the possibility for health activists, local health activists, to make a difference is the discourse around asset-based community development, right? So I think it's really, the one thing that has done is shift us from a deficit model to a strength-based model and recognize that no matter how disadvantaged the community, they have enormous strengths. I think that's really important. But what it's done is shift the focus away from power, right? So now we have this inward gaze, dominant in many, many places around the world, of local health workers on the community. and tending towards behaviour and lifestyle, although I think that varies a lot, rather than the outward gaze, which was, of course, in Alma Ata and, you know, all of the grand statements about community empowerment and health promotion, that actually what this is about is social transformation and political change. So out of that comes the support role, the knowledge exchange role, the recognition of strengths, etc. But also do power mapping before you do asset mapping. Think about power dynamics, and there's lots of tools out there that can help people to do that. So I would like them to bring power back into the center of their work and think about the power they bring and they can use to advocate, the power that other people are using to limit these communities of interest ability to improve, and the power that they can collectively have with services and other professionals and these communities to change things, to pursue social justice. It would be great, wouldn't it, if the banner of the next cohort of community workers was that they're workers for social justice, not workers for community health.